was delayed, so we will not having any questions. Maybe at the end of the session we can discuss that, and I will ask Dr. Batkov to present his experience in modular IOL of his own design.
Hello, everyone who stays awake in this afternoon time, which is usually a problem. It's ridiculous to say about the time now because we are late for 1 hour, so let me not to fail as much as the organizing committee did. First of all, I would like to introduce my co-authors. These are two great guys who did all the surgery in this study. Well, I have to confess that I'm not good enough to suture the cornea, but I'm an expert at cutting it. Well, I think we'll skip some basics, and as you well know, that cornea and lens are the principal parts of the optical apparatus that forms the image on the retina. And when we encounter combined simultaneous cataract and corneal disease, we know some important points in this. As you will understand, refraction is primarily an issue for penetrating keratoplasty, which involves air-cornea interface. The same is true for DALK, which also interferes with the air-cornea interface. We also know that refractive accuracy is far more greater in a stage surgery. And triple procedure we have to encounter in several situations when we see advanced cataract. There could be an argument that PKP is getting a thing of the past, with endothelial lamellar techniques conquering the globe. This view is only partially true. Even in the so-called developed world, the combined share of penetrating keratoplasty and DALK is far from disappearing, approaching 30 to 40% of the total. But when you consider more populous regions of the world, this share rises to 80 and 90%. I think the best tribute to the importance of refractive issues post-keratoplasty is the multitude of approaches developed to mitigate the problem. Everything from spectacles, contact lenses, to repeat transplantations are done in this case. A lenticular part is also a part of the equation. One way, not very popular, not very mainstream way of dealing with the problem is to use modular lenses, intraocular lenses with a replaceable optic. I have to admit that the concept of a modular IOL is neither new nor dead one. The approaches have been tried in the 90s, and they are not dead, and they are still being pursued currently. We have come with our own, and one important piece of logic behind this design is, so to say, manufacturer or technology independence. All of the complexity of repeatable assembly and disassembly of the device went into the haptic part, implanted once during the primary procedure. And that's it, you've got a lifetime IOL support. Whenever the need arises for optical power to be changed, or any other circumstance like clinical change or technological development, there's a permanent optic holder permitting any discoid-shaped device to be implanted in the future. It is in fact an open platform, not particularly restricted to any specific manufacturer or technological process. And importantly, the design also boasts unlimited optic rotation, which is toric compliant. These are some technical details of the implant, which are pretty standard. Notable is the hydrophobic nature of the material, which is important for posterior lamellar techniques. The optical disc is 5.5 to accommodate a larger haptic ring around it. So the purpose of our study was to evaluate clinical feasibility of primary modular IOL implantation during combined cataract and keratoplasty surgery. There were 36 primary implantations in this study, with the preponderance of females among the subjects. We have not done optic exchanges yet. Age distribution is heterogeneous from late 40s to late 80s, and current overall follow-up is rather short, with half of cases less than 3 months after the surgery. The indication table is a snapshot of our patient base dominated by full thickness opacities, scars, multiple graft failures, a bunch of perforating ulcers, and chemical burns. We start our video gallery with a DMAC case, illustrating the advantages of phaco in a closed environment, taking advantage of the foldable nature of the implant, which is assembled ex vivo in a dry setting. The assembly process is pretty straightforward, short, and minimally interfering with the standard protocol, as you can see on this video. It's implanted in the cartridge in a methyl cellulose containing viscoelastic, and in a standard fashion implanted into the bag with little manipulation to deliver the trailing haptic. And the DMAC part is finished in a regular fashion with stripping decimate membrane, injecting the graft, and lots of tapping and prayer. This acute eye drops case with the nuclear cataract requires a completely different skill set. Still, there's a place for a controlled capsular opening, as you can see here. Yeah, the nucleus is expressed by hydro procedure. And even there's a place for automatic cleanup. The pre-assembled lens is placed into the bag, step by step, in an open sky environment. And the corneal button is securely and hermetically sutured in place. To illustrate the exchange part, I can only show you a vitreoretinal case where the optic is being exchanged at the time of silicone oil removal. The optic is dislodged into the anterior chamber, the tunnel is refreshed, the optic cut with IOL scissors, and removed. The replacing optic goes in a standard fashion and by manually guided into its place under two fixation leaflets that hold the optic in place. We just check out the first one. In this study, we were obviously lucky not to see any major IOL-related issues like dislocations, spontaneous disassembly, implant damage during implantation. There was one case of fibrinous membrane around the implant. Though we have to admit this study was not designed to measure such important things like uveal biocompatibility, power calculation accuracy, and relation of the optic to the eye's visual axis. When collecting the data for this presentation, I was amazed at how ill the cohort was cornea-wise. We've got a fifth of grafts failed, multiple persistent erosions, even a psychiatric patient rubbing his eyes obsessively, so that's why we got a lot of wound dehiscences in this study. There were some non-corneal secondary surgeries for the pre-existing conditions that accompanied these patients. In refractive terms, we reasonably got a dispersive picture. The lamellar cases shown in red stand out by being close to zero, while penetrating ones landing anywhere from +10 to -6 sphere, with the majority of cylinders in the up to 4 diopter range. Not pretending to be talking about a universal one-fits-all solution, still in the process of mental digestion of the outcomes, we envisioned that modular IOL approach adding value to high-risk patients undergoing penetrating keratoplasty in an inflamed environment where cataracts develop early and grafts fail easily. High life expectancy is a dominant hardcore factor. Simply having more time for an eye to develop refractive change, world to experience a technological revolution, and brutally for a graft to fail makes a tremendous difference. Possibly, we can also look at elder patients with endothelial disease and rather clear lenses, knowing that within 3 years of corneal transplantation, they will require cataract surgery. If we can undeniably prove that optic replacement is safer to a transplanted cornea than a full-scale cataract removal. Well, to summarize, keratoplasty patients with cataract present difficult refractive challenges. Primary modular IOL implantation is minimally disruptive to common operative technique and has a good safety profile. Cylinder correction is a must for a device aiming for a keratoplasty population. We're still early on the data acquisition curve regarding optic exchange, and time is also needed to prove the long-term stability and centration of the implant, its capacity to maintain durable disassembly capability. And thank you very much for your attention.
Thank you very much, Dr. Batkov.